The battle against chronic disease is being redefined by groundbreaking research, but political agendas threaten to undermine these scientific advancements. The traditional divide between infectious and non-communicable diseases is crumbling as new evidence reveals that viral pathogens are not just fleeting dangers but persistent catalysts for chronic conditions, particularly cardiovascular disease, CVD. A comprehensive review by Dr. Kosuke Kawai's team at UCLA, published in the Journal of the American Heart Association, October 2025, analyzed 155 studies, confirming a strong link between viral infections and subsequent cardiovascular events. Acute infections like influenza and SARS-CoV-2 led to a 4-fold increase in heart attacks and a 5-fold rise in strokes within a month, while long-term infections such as HIV, hepatitis C, and herpes zoster were associated with higher risks of coronary heart disease, CHD, and stroke. This paradigm shift challenges the federal health policy led by Robert F. Kennedy Jr., who, despite vowing to combat chronic disease, promotes anti-vaccine views, dismantles vaccine advisory structures, and reduces investment in immunization and infection prevention. Kennedy's actions contradict the emerging scientific consensus that chronic diseases are often the delayed consequences of infections, emphasizing the need for a unified approach to public health. The UCLA study highlights 2 critical aspects of viral impact: acute short-term risks and chronic, long-term burdens. Influenza infection quadrupled heart attack risk and quintupled stroke risk within a month, while COVID-19 caused a 3-fold increase in myocardial infarction and stroke risk during the first 14 weeks, with elevated risks lasting up to a year. Long-term data showed a 74% higher CHD risk and a 69% higher stroke risk among those previously infected, indicating that infections like COVID-19 are just the tip of the iceberg, causing widespread inflammatory and vascular damage. The study also revealed that viral infections can cause lasting cardiovascular harm, with HIV increasing CHD risk by 60% and stroke risk by 45%, and hepatitis C virus, HCV, elevating CHD risk by 27% and stroke risk by 23%. This pattern is exacerbated in populations with pre-existing risk factors or limited healthcare access, disproportionately affecting low-income communities and low- to middle-income countries. Beyond CVD, infectious agents are now recognized as initiators or accelerators of cancers, autoimmune conditions, and neurological disorders. A 2020 Lancet Global Health study estimated that 130 million disability-adjusted life years, DALYs, from non-communicable diseases are attributable to infections, a conservative estimate. This reconceptualization has significant policy implications, suggesting that interrupting infections early can prevent irreversible chronic diseases, as seen with peptic ulcer disease in the 1980s. The COVID-19 pandemic serves as a cautionary tale, demonstrating how a single infectious agent can lead to a massive non-communicable disease burden. In the U.S., COVID-19 deaths exceeded 1.2 million by October 2024, but the true toll is higher. Excess mortality, including indirect causes like delayed cardiac care and rising overdoses, reached 3.63 million between 2020 and 2023. Even as acute viral mortality declined, overall death rates remained high, reflecting long-term infection sequelae and a weakened public health infrastructure. The "let it rip" approach, characterized by premature reopening and minimal infection control, allowed uncontrolled viral spread, resulting in preventable deaths, disabilities, and chronic illnesses. The pandemic highlights the interconnectedness of infectious disease policy and chronic disease prevention, emphasizing the need for an integrated approach. The surge in cardiovascular deaths during the pandemic, particularly among younger adults, underscores the direct vascular and inflammatory effects of SARS-CoV-2. This trend contradicts the anti-vaccine myth propagated by groups like Make America Healthy Again, MAHA, which falsely claims that COVID-19 vaccines cause excess heart attacks and strokes. Epidemiological data show that the rise in cardiovascular deaths began in early 2020, before any vaccine authorization, and closely tracked infection waves, not vaccination campaigns. Large systematic reviews refute the anti-vax narrative, finding no consistent increase in cardiovascular events after COVID-19 vaccination, and often reduced risk compared to unvaccinated populations. The claim that vaccines triggered the cardiovascular mortality rise lacks scientific support, and groups like MAHA divert attention from the infection-chronic disease link, where vaccines play a protective role. Socioeconomic factors significantly influence the chronic disease infectious trigger-patient outcome relationship, leading to profound inequities. Low-income communities face higher cardiovascular hospitalization rates and greater burdens of diabetes, hypertension, and chronic respiratory disease, while higher-income neighborhoods enjoy lower disease prevalence and better access to preventive care. The COVID-19 pandemic exacerbated these disparities, with excess mortality highest among populations with low vaccination rates, due to policy failures and inadequate social safety nets. Vaccines offer demonstrable protection against infection-triggered cardiovascular disease. The UCLA meta-analysis confirmed that viral infections like SARS-CoV-2, influenza, and herpes zoster significantly increase cardiovascular risk, and vaccination can reduce this risk. A 2025 Nature portfolio study found that pre-infection COVID-19 vaccination reduced major acute cardiovascular events by 30% and all-cause mortality by 70% in the year following infection. Further studies have quantified the protective effect of vaccination across various pathogens, vaccine types, and dose schedules. The landmark influenza vaccination after myocardial infarction, IAMI, trial showed that administering an influenza vaccine during hospitalization for an acute myocardial infarction reduced cardiovascular death and major adverse events by 41% over 1 year. A 2023 sub-study found that early vaccination during hospitalization produced the most significant reduction in all-cause mortality. Similar findings apply to COVID-19 vaccination. A 2024 meta-analysis reported no overall increase in heart attack, arrhythmia, or stroke risk following vaccination, and a clear protective trend after booster doses. The third dose was associated with an 81% lower stroke risk and a near 100% reduction in myocardial infarction compared to unvaccinated controls, aligning with large-scale population analyses. The European Society of Cardiology's 2025 Clinical Consensus Statement, published in the European Heart Journal, represents a historic shift in cardiovascular medicine. It elevates infectious disease prevention, especially vaccination, to a foundational pillar of cardiovascular prevention, alongside blood pressure control, lipid management, and glucose regulation. The statement affirms that vaccination is a core intervention in chronic disease prevention, reducing major cardiac events linked to various infections. This scientific consensus exposes the reactionary and anti-public health agenda of groups like MAHA, which deny these findings and portray community immunization and disease surveillance as infringements on personal freedom. Their rejection of vaccination reflects a broader ideology of hyper-individualism, subordinating collective welfare and scientific reality to private profit and political manipulation. The new understanding of non-communicable diseases as downstream consequences of infection marks a turning point in medical science, akin to the germ theory revolution. It erodes the divide between communicable and non-communicable diseases, allowing for unified prevention strategies. However, this consensus is threatened by a historic life expectancy crisis, with the U.S. experiencing the largest two-year decline since World War II, losing over 2 full years of life expectancy compared to pre-pandemic levels. This crisis reveals a structural failure, where public health is subordinated to private profit, and biological outcomes move in the opposite direction of scientific potential. The catastrophic decline in life expectancy is a social catastrophe, not a natural fluctuation, and is linked to the same political forces that dismantled public health, privatized medicine, and subordinated scientific policy to corporate profit. These forces now weaponize anti-vaccine and personal responsibility narratives, marking the degeneration of capitalist governance. Breakthrough research, like the UCLA meta-analysis, confirms the scientific basis for prevention: infection drives chronic disease, and vaccination prevents it. However, this framework is under sustained political assault, with the dismantling of pandemic surveillance, defunding of infectious disease research, and removal of vaccine recommendations. These are conscious class policies, designed to reconcile profit accumulation with mass morbidity. The defense of life expectancy and the restoration of public health require a revolutionary transformation. Only the international working class, organized independently on a socialist program, can secure universal vaccination, equitable healthcare, and democratic control of science and medicine, ensuring genuine public health and a future for humanity.